There's a lot to cover in 7 minutes, so I'll get right to it. And I was assigned the task of a purist perspective, and we'll see in the next talk maybe a more practical perspective. This is the situation that we're dealing with in shock, patient with reduced inotropic state, reduced end-systolic pressure-volume relationship, reflecting the decrease in contractility, decrease in blood pressure, and decrease in cardiac output. Also, we should remember, and it's been brought up a few times, that there is also the potential for biventricular involvement. So we also have to think not only about the left ventricle, but the right ventricle. One thing that I think is really critical is to note that the hemodynamic response to device and drug therapies varies among patients due to the fact that the baseline characteristics and secondary effects that vary from patient to patient. So the degree of RV and LV involvement and compromise, the short-term recoverability, the SVR, the PVR, et cetera, all impact on how a patient responds to a particular form of mechanical support. So here's a prototypical response to a balloon pump. You see a little bit of a reduction in blood pressure, a little bit of a reduction in wedge pressure, and a little bit of increase in stroke volume. And you know that the results of the clinical trials did not show very big effects. Here, in contrast, is what happens with a left ventricular assist device. You see blood pressure goes up, ventricular pressure goes down, the heart is unloaded, and you see a reduction in wedge pressure, end diastolic pressure, reduction in the pressure volume area, meaning a reduction in the oxygen consumption. And that is a theory, but in practice, you can also see the same kinds of pressure volume loop transitions. This is from Bill O'Neill's group with the collaboration that we've been establishing with his talented interventionalists that can measure these loops in real patients. You see on the left without Impella, on the right with an Impella device. And this is another example in an animal model of cardiogenic shock. You see in the middle the shock state, and on the right the pressure volume loops during Impella support with the triangulation and reduction in the end diastolic pressure. In contrast, tandem heart has a reduction. You have a reduction in end diastolic pressure and wedge, but you also have an afterloading effect that you see, that we're going to see also in ECMO. So there's a balance here between a reduction, a preload reduction, but also you have an increase in afterload due to the increase in blood pressure. And here is an animal experiment showing the difference between baseline and then during LA to aortic pumping. You see this, again, the reduction in preload, but the increase in the afterload, which is a very different effect than what you see with Impella. And here is ECMO, and in this case, in this simulation here, you see that ECMO does not unload the heart, and this is because of the need for the heart to eject into a higher afterload pressure, and that results in the need for retention of blood in the ventricle to overcome the new increase in blood pressure that's potentially beneficial to the body, but may potentially detrimental to the heart. And here you see, again, the top line was the experiment with Impella. Bottom line is the same animal model. Again, on the left, normal cardiogenic shock, and then you see here during ECMO, there's no unloading, and also the aortic valve's not opening. The pressure volume loop is straight up and down, isovolumic contractions. And that goes hand in hand with the development of pulmonary edema, the stasis in the left atrium, left ventricle, and the formation of thrombus that I'm sure some of you have seen, many of you have seen. Here's another example of stasis in the aorta while on ECMO, and here's examples, dramatic examples of LV thrombus. And this is from Dr. Carr's work, both theoretical and practical, showing with tandem heart and with ECMO the issues with stasis. So obviously now the other thing that we need to consider is what happens when you combine devices. This is ECMO plus Impella, and you see that addition of a left ventricular assist device is one of eight different ways that one has to deal with aortic valve, a reduction in aortic valve opening and LV overload that you can see during ECMO support. This has been very popularized, and here this is from a collaboration with Dirk Westerman. And you've seen this slide about 4 times today, showing a patient presenting with a wedge pressure of almost 40, being put on ECMO, and wedge pressure going up, and then being put on Impella, and you see a marked reduction and very rapid reduction in wedge pressure. So I emphasize that the hemodynamic responses are modified by changes in LV and vascular properties that may occur. So here, for example, is a difference in a response. If you have a left ventricle that may show some recovery during the initiation of tandem heart response. And you see here a very different response, that there's more unloading that you get, and also the end systolic volume goes down a lot more when you have a bit of recovery during the initiation of MCS. And here's from Naveen Kapoor's lab, showing the exact same thing. The loops in black are the baseline cardiogenic shock state, initiating tandem heart, and you see that you have much more reduction in EDV and also end systolic volume when you have heart recovery as a consequence. And here you see the same thing that would happen with ECMO. If you have recovery of function, you're not going to have a significant amount of loading, and I think this is one of the key factors that contributes to the fact that not everyone on ECMO needs unloading, that there is potential for LV recovery and ability to overcome the blood pressure that is imposed on the heart. The other thing, the same kind of phenomenon would happen with a ventricular assist device. Here you see that with a ventricular assist device, the degree of unloading is amplified by the fact when you have a situation where there is LV recovery. And here again, you could see here in these experiments, if you compare the middle panels to the right panel, in both cases, the contractility, the end systolic pressure volume relationship, is improved by the presence of either the Impella or by the presence of ECMO. It's just in the ECMO state, it was not able to overcome the increased afterload. So in summary, the Purist view, the theoretical view of all of this, the simulations largely recapitulate data in human and animal studies. We don't have a huge amount of physiology data, but there is a recapitulation. The simulations highlight that the response of different forms of MCS have fundamentally different effects on the heart and the lungs. And this is why we think that PAC use can be helpful to customize and optimize MCS in these settings. So I think we're going to hear debates about unloading, ventricular unloading, and also about the use of PAC. And I think that two of the take-home messages are what I've highlighted here, is that it is critical, important to recognize that the different devices impact the loading differently. So, no matter what we hear, different devices unload the ventricle differently, and we have to recognize that. And second, what I've emphasized is that the patient responses to any given device can vary significantly because of a multitude of factors, and I think that's really where the PAC comes in to be able to customize therapy. Thank you.
Any questions?
I'll ask one since no one else is. Dan, you're the world's expert on this stuff. The issue with the pulmonary artery catheters, as you know, is that they're often difficult to place in someone that's already on ECMO just because the cannulas are all in the way. If you have ready access to an echo machine, do you really need it? I mean, you can see all that information on an echo, and a chest x-ray shows you whether or not the congestion's getting worse. So you could usually, I think, get by without a PAC if you have that other information.
I think that, first of all, just looking at arterial pulse pressure tells you a lot about aortic valve opening. If the more pulse pressure you have, the better. I think you'll have a central venous, it's more easy to have actually central venous pressure with a central line. So really, what do you really get extra from a PAC? And I think we'll probably hear about this in the debates. But in my mind, number one, I don't think that there's a good measure for wedge pressure non-invasively. And I think also that if you wait until there's congestion on the chest X-ray, you're missing the boat. You're behind the 8 ball. And a lot of patients, that's, if you read some of the literature, what are the indications for initiating unloading? One of them, a lot of them are, these algorithms say when the patient gets congested. I think that you want to avoid the congestion. Everything that we've been talking about is don't get behind the 8 ball, normalize the hemodynamics as quickly as possible. I mean, having a patient with pulmonary edema, even if it's an hour, 2 hours, 12 hours between x-rays, I don't think that does not feel right.
I have a question from a practical point of view. I assume that the ability to measure the native cardiac output will help. So one of my questions is, what are practical approaches? And I do remember a study we did many years back in which measuring the end-tidal CO2 was a good way of separating and measuring the native cardiac output, because you have to go through the lungs when somebody's on ECMO.
Yeah.
And whether the target of the aortic pressure will make a difference, whether you go a bit lower or things like that.
So that's two separate questions. One is you want to be able, it would be ideal to be able to measure the contribution of your LVAD and of your native heart to have some index of intrinsic ventricular contractility, ventricular ability to contribute to the cardiac output. That could maybe be more, even more important and useful during weaning. To be able to predict who can, who will be able to, overcome or maintain cardiac output when you wean the device. And it is a big challenge. Now, there are some algorithms that are being developed, I know, for the Impella device that are trying to sort out and being able to ascribe how much of the total cardiac output is from the Impella and how much is from the native heart by looking at things like pulse pressure on top of the Impella. With ECMO, obviously, it's a lot more difficult thinking. I've been involved with a few discussions about, does Swan-Ganz, work in the setting of ECMO? And I'm not sure I know the answer. And you can make arguments on both sides that it should work, it does work, but I don't think that we know for sure. It is a challenge, and it would be very good to be able to look at those. Ali, you have a...
I agree with the concept of unloading. We have to look to the unloading and see that the ventricle unloaded appropriately to achieve some recovery. The problem we have, we're putting all ECMOs in one category. ECMO depends on the size of the cannula using, the flow you are using. And that's the problem we have, probably. We have some people utilizing 15 French arterial cannula, 17 venous cannula, running that with 2.5 liter. You might not be able to unload the ventricle appropriately with that way. That we have to be careful when we look into the things to say what kind of flow you're having, because the CT surgeon are doing ECMO every day in the operating room, and not in every case you are going to have to put a left heart drainage to unload the left ventricle. That means this ECMO, for a certain degree, can unload, because you're taking 5 liters from the right side of the heart, you're reducing the preload of the heart, of the circulation of the left side. If you're taking 4 liters or 5 liters from that, and you're putting that in a cardiogenic shock patient who is usually per se have low blood pressure, you are normalizing the afterload. You are not increasing the afterload. You're getting from mean pressure of 60, you're going back to 80. That's something we have to...
Ali, I think it's very straightforward. The amount of the response of the ventricle determined by the flow of the ECMO, no question, the blood pressure that you achieve, the residual contractility of the heart. Think about the two extremes. You put a normal person on VA ECMO, they're not going to get loaded, right? They're going to be able to deal with the afterload. You take a person that has ventricular fibrillation with no function, that heart is going to get loaded. There's not going to be any ejection. There's still going to be return to the heart, venous return, right, through the bronchial circulation and Thebesian drainage. This is why surgeons put in LV vents even when they're on total bypass, is because you still have return, am I right about that? You still have, drainage. So those are the two extremes. So the patient exists between these two extremes. And the same thing is true for blood pressure, and the same thing is true for when you determine the flow that you're providing.
I just want to, as a CV surgeon doing cardiopulmonary bypass every day, respond to Dr. Banoyos's statement. In the operating room, in the cardiopulmonary bypass, we have a reservoir that is totally different than ECMO. Yes. So it is a reservoir, it just collects the blood about more than 2 liters sometimes. That's right. That you don't need to unload it. Yes. You just drain it into and you run the blood with a...
Exactly to your point, if we take, even in the simulations, that we use, if I take the simulation and I take volume out of the circuit, which is what the reservoir is for, no pulmonary edema. It's unloaded. But that's different when you have a closed system where you're not taking blood out.
I think it's important to understand, the particular patient we're dealing with.
Yeah.
As you mentioned, the
Absolutely.
blood pressure, the residual ventricular function, and how much flow you are flowing with ECMO, and then to determine which patient needs unloading, and not to say every ECMO patient should be vented.
Right.
Per
Well,
se.
I think we're gonna have a debate about that.
Do you guys ambulate patients if they have a Swan-Ganz catheter? I'm right all the way in the back bencher.
Do you ambulate patients with a Swan-Ganz catheter? If you unhook it, yes.
Yeah, if I insert ECMO with the intent that I'll be able to ambulate this patient, my hospital's okay with ambulating the patient on ECMO, but they're not okay with a Swan-Ganz catheter.
You mean because of fear of safety of a tip in the pulmonary artery?
Patient safety.
Because of what? Because of a catheter in the pulmonary artery?
Because the
Is that
catheter does not have a good locking mechanism as opposed to ECMO that I can secure.
Yeah. I would assume that your hospital also doesn't let you get wedge pressures because it's unsafe. So I don't know.
Thank you, Dr. Burkhoff.
Okay,
That's
thank you.
fantastic.